Okay, so I have no financial disclosures, although my father-in-law does talk for all of the biologics and does take me on vacation every February. So we all know these patients with scleritis. They're difficult often to treat. This is a 32-year-old African-American female with a 2-month history of pain that's not responsive to topical medication sent into you. And so I'd like to kind of think about this patient as we go through what our different options are. So we're going to do a workup for this patient, and then what are our treatment options? When do we add steroids? What kind of steroids? When do we add other immune modulating therapy, and what should that be? So the first thing when we're treating scleritis is to make sure that it is a non-infectious scleritis. This is a patient with not getting better after 2 months of oral prednisone 80 milligrams, came in to see us, and Chris did a culture because it looked a little funny there, and it ended up being nocardia, which responded very well to Bactrim and very poorly to oral steroids. So something that we think about, we don't often see, but if it looks a little funny, culturing it's a great idea. So when we think about the cause of the patient's scleritis, SN presented the series from Wilmer a few years ago now, looking at what we find in these patients. 44% of them do have a medical condition, most of those rheumatologic, and 56% don't. In terms of the rheumatologic, it's interesting to know what they have because that may help direct the therapy. The vasculitis patients, Wegener's patients, tend to often need a more aggressive course, such as cyclophosphamide or Cytoxan, whereas the inflammatory bowel disease patients never get treated with that medication and are more likely to do well with Imuran or another agent. So something to think about as we see these patients. So Wegener's patients tend to be very aggressive and severe patients, and unfortunately the name is not Wegener's anymore. It's Granulomatosis with Polyangiitis, because even more unfortunately, Dr. Wegener was associated with the Nazi regime. When we see these patients, of course, our goals are to treat the inflammation and then treat the cornea if that is also involved. We can use nonsteroidals, especially if it's mild disease and non-necrotizing disease, and we don't use these in combination with steroids. We often use Indocin with very good efficacy for the mild patients. But if the patient's not getting better on NSAIDs or they have a more aggressive course, certainly going to steroids are something that we would consider. And often at that point we would go to oral steroids. But I just want to make mention about using subconjunctival steroids for scleritis. And I trained at Wilmer, where Doug Jabs believed that you never, ever, ever did injections for scleritis because of the risk of necrotizing, converting this to a necrotizing process. But over the years, I've certainly had patients, and there have been many case reports, and even Dr. Jabs wrote a recent article that it probably was safer than the original papers. And so in some patients, probably not in this patient where I hadn't tried oral therapies very much, but in a recent patient I treated with this was someone who had been through oral steroids, Cellcept, Imuran, and the discussion was Cytoxan, and that was pretty scary to a young woman who still was considering having children in the future, although she had twin boys, so she wasn't thinking about it too much. And so I did an injection of Kenalog in a couple spots, just subconjunctivally, with really impressive improvement in her pain, and she didn't really care so much about the white spot after a while. But you do have to warn them that there'll be a white spot. And just in terms of how we do with local therapy versus oral immunosuppressive therapy, the MUST trial came out recently, which compared the Retisert implants, and this is for all comers in uveitis, mostly deeper uveitis, intermediate and pan-uveitis. And they showed that immunosuppressive therapy did as well as local therapy with the Retisert implants. Both those patients did about the same in terms of control of inflammation and vision, but the Retisert patients had a lot more ocular complications, 80% of them requiring cataract surgery and 60% of them requiring medicines for high pressure. So the immunosuppressive oral agents are pretty good in a lot of these patients. Of course, our first line to go to would be oral steroids, but we can't rely on them for too long because of the complications. And we all have this the patient, like this patient, who does great on oral steroids, and then as soon as you taper them, they flare their disease. And there are some recommendations about when we should think about adding another therapeutic response if the patient's disease worsens on oral steroids, if it doesn't respond, or you're not able to get them off of oral steroids or down to a low dose in 2 to 4 weeks, or if it's not completely quiet after a month. And those are old recommendations, but good. So let's say that that's the case with this patient. Then the next choice is to think about our other immunosuppressive agents. The review of this literature reminds me that I'm really happy I'm an ophthalmologist, because these are a lot, but I'll make it really easy. We have the weaker but safer medicines, such as Imuran, Methotrexate, and Cellcept, and then the stronger but more dangerous. So it kind of depends on how sick the patient is, how severe the disease is, as to where we're going to go. And the SITE study is John Kempen has directed this out of Shea and has pulled ocular inflammation data from many centers. And this is his kind of one of the Doug Jab's take on it is any one drug works about 50 to 70% of the time, and any approach works 70 to 85% of the time, but nothing works 100% of the time. So I'm not going to go through each of these too much, except to say the scleritis results. So with methotrexate, about 40% of patients were able to be tapered to less than 10 milligrams of steroids in 6 months, and about 60% at 12 months with methotrexate. It's not a good medicine for young drinking or older drinking patients because of its liver issues. This is a patient of mine who did well with methotrexate, but it took 9 months for her to get quiet on it, and she was willing to wait, although I was a little bit antsier. Imuran is another good medication that we have, but none of these are great for scleritis. 22% of patients with control at 6 months, 35% at 12 months. And Imuran does cause bone marrow suppression, and so we can now test an enzyme before a patient gets placed on Imuran to see if they are going to be at high risk for bone marrow suppression, and that's something that that we would hope that the doctors that we're sending these patients to, or if you're doing it yourself, are looking at. We have a lot of experience with Cellcept for pemphigoid, which I'll talk about in just a second. But in terms of scleritis, it had corticosteroid success in 26% of patients at 6 months and about 50% of patients in 12 months. And cyclophosphamide, which we think of as a much stronger agent, but much riskier in other ways, had success at 50% at 6 months and 76% at 12 months. All in, but for the scleritis, it was 30% and 60%. And we have to worry about cancer a little bit more in that group. So the Scleritis Results All In, when I looked at this data, at 6 months, we have corticosteroid sparing success in 22 to 53 and then at a year, 35 to 60. So not great, and certainly lower than for other indications. This is a patient that I saw recently who has a resolving or almost resolved scleritis and psoriasis. And he said to me, well, I'm here, to get my eye checked, and then I'm going to get started on these biologics because I know they're much better for my eye than any of the other therapies. And I started thinking about, well, who's told you that it's much better? And what we know about the TNF inhibitors, which is usually the big group of these that we use, is that they're faster, they're more likely to cause remission, but there's less safety data, and there is some data that there may be an increased risk of cancer in these patients, and so it's something to think about for the future. We have different options for the TNF inhibitors. We have Infliximab, which is Remicade, the oldest, the most tested, Humira, which is another anti-TNF antibody, and then the Enbrel, which is the receptor, which is usually thought to be weaker for the eyes. Infliximab, as I said, is the most studied in the eye. It's actually approved for use for Behçet's disease in Japan. And any of these medicines do have some risk of a lupus-like syndrome when they're given. As I said, a couple small case series, and if you look in the literature, most of it is called small case series for these agents. B-cell-based therapy, we can also think a Rituxan or a rituximab is used, and it's been used in some patients with Wegener's with good success in orbital inflammation and scleritis, and has also been used with pemphigoid. This is a patient of mine with rheumatoid and an indolent scleritis, but a necrotizing process previously, and then his other eye got involved, and at that point he agreed to have therapy, and his doctor wanted him to be on Rituxan, and he did quite well with that. I'm going to skip this and just go for the last couple minutes here on and talk a little bit about pemphigoid. Pemphigoid is something that Irv and I and Bob Penny work in our special little clinic once a month, and we have, over the last, since I've been here, using CellCept as our primary therapy for many patients with pemphigoid, although we have a lot of choices. And we recently, through heroic efforts of 2 years ago, Jennifer Nottage, who was a fellow 2 years ago, have gotten published our case series. Prior to this case, there were only 28 patients in the literature, and we added our series, which showed very good success in controlling the inflammation, 83% controlling inflammation with CellCept, and we found this drug to be very safe and very well suited for our elderly patients with pemphigoid, which they often are. A few of them failed, and a few of them needed additional therapy. And I'm just going to close with a patient who was one of our failures, and a patient who came in from a Lod-Feldman to our pemphigoid clinic with bilateral, very active pemphigoid, one eye with a big persistent epithelial defect, which went on to perforate. And luckily, Brad Feldman was on call, not a Lod, and Brad did a amazing full thickness, just stuck a big cornea on this terrible melted eye, and unfortunately, in follow-up, her other eye, which is this eye, went on to very aggressive keratinization and an end-stage pemphigoid until we get some of these procedures a little bit better with the cultivated options. And so her eye that had been patched actually had a good tear film and looked much better, and so we made the decision to do a keratoprosthesis. And Bob Penny and I have played multiple times with trying to get the lids sutured around the K-Pro. But the patient went from being blind in both eyes, I actually thought that she was just ready to die because she was so depressed, to asking all the time about if she can drive. It was really an amazing, one of those amazing cases, and I think it showed nicely how the cornea service took care of this patient through the many phases of her illness. And thank you very much.